So like everybody, every time, in between we took a long break this time because of the Diwali and all those festival times. And even I had gone on a vacation. So we are back with our once a week webinars. And I welcome Dr. Taruna Girish, our guest of honor this time, to empower her with some wisdomful inputs. Just introducing Dr. Taruna. She is a renowned gynecologist in Bulandshahr. She's a senior consultant. She's a graduate, graduate and postgraduate of KGMC Lucknow, and she has papers published in many Indian and international journals. She has been a past president of Bulandshahr Obs-Gynae Society and has a clinical experience of 30 years. Her special interest is adolescent health. I think some word is missing, and we have worked together. And she's a very helping person and a friend to everybody, and a very good painter. This should be inspiring to all of us. She has lot of other interests, painting and gardening. She keeps sharing her beautiful garden pictures. So, Dr. Taruna, welcome. And today we are going to talk about Isthmocele. So, some introductory words from your side, so we can start. Your voice again. You have to unmute yourself. लास्ट में म्यूट बटन है, वहां पे आप अनम्यूट कर लें प्लीज. I have with me Dr. Pinky Singh and Dr. Garima Sinha. They are my fellows. He has recently joined, and we have this Excel Academy, so we have online, offline trainings and fellows with us. Dr. Garima is a current fellow, and she'll be presenting the case after inputs from Dr. Taruna. Can you unmute yourself? पिक्की चले जाओ, पिक्की साथ में लेके चले जाओ, 2 ग्लास. Not that we can start, Dr. Taruna. Dr. Taruna, I think अब आप unmute हो गए.
Yeah, I'm unmuted.
So we can just have you with us.
Yeah.
बोलने से आवाज नहीं कर रहे हैं, 5-10 मिनट के ना आधे घंटे आवाज.
So Dr. Garima is going to present right now. She's going to present. Dr. Garima is going to present right now.
Yeah, I will. So should we start the presentation? Because
I
your
think
voice is not very clear to us.
Yeah.
Volume, I'll increase the volume. Dr. Garima, do you have your PPT ready? Yeah. Dr. Garima will be presenting the case. Yeah, it's visible now. It's on the screen.
Unmute. Good afternoon, everybody. I'll be presenting.
This was an interesting case who came to us. We have seen few cases of Isthmocele, but Dr. Garima will be presenting this case.
Good afternoon, everybody. I'll be presenting the case report. So a 41-year-old female came to the gynae OPD with a history of 6 months long irregular uterine bleeding in the form of prolonged menses and intramenstrual spotting, which was dark brown colored, off and on, and with lower abdominal pain, which partially relieved on rest. Her obstetric history was P2L2A1. She had 2 cesareans. The first one was 13 years back in view of non-progressive labor, and the second one was 11 years ago in view of previous LSCS. She had 1 MTP, 1 year back, done by MTP pills. Her past medical history, she was a known case of hypothyroidism and on medication since 4 years, Tylenol 170 micrograms. Now coming to the examination, her PS examination revealed her cervix was mildly bulky with minimal bleeding. On PV examination, her uterus was about 8 to 10 weeks in size, anti-verted, mobile, and both the fornices were free. On her TVS evaluation, an isthmocele was noted in the lower segment with intracavitary clots and a small intramural fibroid, along with a functional cyst of 3.3 centimeter in the right ovary. Her endometrial thickness was 5 mm. A partial defect was noted in the lower segment, uterine scar with a triangular fluid collection of 2 mm within the defect, suggestive of a small isthmocele. Residual myometrial thickness was 2.9 mm and intracavitary clots seen were 13 mm. We did a hysteroscopy, endometrial biopsy, and isthmocele repair along with Mirena insertion for the patient. The endometrial biopsy revealed secretory endometrium. The patient was discharged on post-operative day 3 without any complications. In her 1 week post-operative visit, she had no pain or irregular bleeding. The patient came back to us after 3 months and she had no complaints of irregular bleeding. Thank you.
So thank you, Dr. Garima. You can stop sharing your screen. So then I'll take you to my PPT. All right. So I will start sharing my screen now. Is my PPT visible? Thank you.
Yes.
That blue colored design.
Yeah, blue.
Sari ka border. Mute kar lena tum. So we'll just go through this. Isthmocele is actually a new entity with increasing number of cesareans. We see this defect. Somebody requested to mute themselves. Yeah. So isthmocele is a pouch-like defect in the anterior wall of uterine isthmus occurring as a complication of a previous cesarean. This term was first coined in 2007. This was described in ultrasound as an anechoic, oval-shaped area located at the level of a previous scar in the anterior wall of the uterus or upper part of cervical canal. 15 European experts, they reached a consensus. They have a Delphi procedure. Mainly it is used in ultrasound. Any defect in such location with a depth of at least 2 millimeters or more is defined as an isthmocele. Previously, it has been known by different names. The disease existed, but it was described by different names such as cesarean scar defect, deficient uterine scar, niche, diverticulum, or a scar pouch. The prevalence can range from 20% to 84%. Actually, now the awareness is increasing both among the ultrasonologists as well as the clinicians. Sometimes we see the defect in the film, although they have not reported. But by the symptoms and that defect in the film, we tell them that this could be isthmocele because many sonologists are not much aware of this condition. Possible risk factors, we'll go to them one by one. Patients can be asymptomatic or they may have gynecological complaints such as any form of abnormal uterine bleeding. It could be post-menstrual spotting. It could be post-menstrual spotting, post-coital bleeding, dysmenorrhea, chronic pelvic pain, secondary infertility, or obstetric complications. If she becomes pregnant, she is likely to have an anterior isthmocele pregnancy, that is ectopic, abnormal placental implantation, and possible uterine rupture if the pregnancy continues to grow. Menstrual symptoms are very specific, so I thought I should have one slide on menstrual symptoms. This is post-menstrual abnormal uterine bleeding, which is 98% of the time it is the presentation. And the patient typically describes this as a discharge of dark-colored hematinic blood-like material, which is collected in the scar pouch during the days of menstruation, and then it keeps on getting released. Presence of isthmocele may show the drainage of menstrual blood through the cervix, and because pouch is a dependent area, so the blood gets collected here, and presence of scar tissue of cesarean scar reduces the contractility of uterus in that area. Another possibility of this collection is blood may originate in that area itself from the stroma of that area along with mucus-like secretions caused by abnormal vascularization around the scar. Whatever the source of blood in isthmocele may be, its presence may contribute not only to post-menstrual AUB but also to secondary infertility by collected mucus affecting the sperm quality and interfering with embryo implantation. The trapped blood is slowly released, appearing as post-menstrual spotting, which is the patient says it becomes dark with time, and sometimes it may happen following intercourse. So what are the causes? Some are patient-related factors and some are surgery-related factors. Patient with one or multiple cesareans, factors which impair wound healing, and those which interfere with proper angiogenesis. A retroflex uterus has been observed to be more commonly associated with this condition. Why? If you look at this uterus, this is the bladder, so this dome is away from the bladder. This means it is retroflex. Now, maximum stretching is happening. The stretch is coming on this part of the uterus. So a scar defect appears to be twice more common in women with retroflex uterus. Flexion point of retroflex uterus is at the level of internal os, determining a significant tension that may alter healing of the cesarean scar, leading to rarely to uterine rupture if pregnancy happens there. Now, surgical factors. During the cesarean, was the closure single layer or double layered? Was it locked or unlocked? Any factor which leads to too tight suturing of the edges of the uterus can also lead to poor tissue healing. Locking has become a little matter of controversy. People say that if you don't lock the first layer, then you get a better RMT. RMT means residual myometrial thickness. This is the recent, but there's no guideline which one locking or unlocking, keeping the first layer unlocked is healthy. It's said to have an endometrium sparing technique. Low location. If the uterine scar is given at in the lower part of the cesarean, which typically happens when the labor has been long, more than 5 hours, or cervix has dilated more than 5 centimeters, then the incision which you give is in the lower part of the uterus. Surgical activities that invite adhesions such as non-closure of peritoneum, inadequate hemostasis, applied sutures, use of adhesion barriers may help. Non-closure of peritoneum, again, most people are not doing, even I have not been doing. Diagnosis is by diagnosis, one second, I just mute the person. Mute. TVS, saline infusion sonography, HSG, MRI, hysteroscopy. Any of the methods you use, the timing is day 7 to 8, just after menses has finished. So we will see remaining blood in the pouch, like the pocket-like defect. Although the ultrasound diagnosis is almost 100% correct, it correlates well. Still, it is better to do hysteroscopy to rule out any other cause, which we'll talk about in the differential diagnosis, because this anechoic shadow can be formed in multiple situations. And isthmocele is typically diagnosed on ultrasound. So let us see what ultrasound looks like. This is the defect, this is the cervix, this is the fundus. And isthmocele is typically diagnosed as on TVS or SHG. Appears like a wedge-shaped defect, if you can see this. My arrows moving? Yes. Achha. And the depth, this depth should be at least 2 millimeter. The indentation into the myometrium should be at least 2 millimeter. Any small bulge cannot be called an isthmocele. And what is important to determine is length, depth. What is the residual this? If you look at my arrow, what I am showing this is the residual myometrial thickness. The thickness of the myometrium above the niche. And what is the adjacent myometrial thickness? What is the invasion towards the bladder? The distance between caesarean scar defect and external os. Is it too close to the os? These are very important factors. A detailed ultrasound by a sonologist who understands our surgical important points should be done. Now, this is again a picture. You can see, compare this hand-drawn diagram with the ultrasound here. People can put... I'll just mute for people. All right. So on MRI, I understand that MRI gives you a crisp, clear image, and when you go in OT, you already have a mental picture, but it is more expensive and less readily available. Hence, its use to detect only the residual myometrial thickness has not shown any superiority over a good ultrasound. Now, differential diagnosis. There could be just dilated cervical glands. It could be a post-myomectomy diverticuli, or a Gardner's cyst like a long tubular structure adjacent to the uterine cavity, or adenomyosis. Location, we have cavities in adenomyosis. They could also look like isthmocele. If you leave these patients untreated, what will happen? If they get pregnant, they may have obstetric complications. If she is not planning pregnancy, nothing may happen. Intraoperative, whatever method you use, there is a possibility of injury to bladder and injury to cervix. Now coming to management. So management can be just watching the patient, medical or surgical. Expected means in asymptomatic woman, if you incidentally diagnose an isthmocele and she has no complaints, she doesn't want to get pregnant, nothing needs to be done. And we should not even reinforce too much that this is one disease you have. Psychologically, she'll start having a lot of symptoms. Medical treatment is good for women who don't want to conceive, first thing. And oral contraceptive, suppose she doesn't want children, but she also wants some contraception advice, then OCP is a good choice for her. Second choice could be an LNG IUD. Although it is not recommended, but it has shown to have good results because it doesn't allow menses to happen. Now coming to surgical, are we going to repair the defect? Repair means totally bringing it too close to normal anatomy, almost normal anatomy. Or remodeling, are we going to make something so that the symptoms stop? So what we do by hysteroscopy is remodeling of the isthmocele, and what we do by laparoscopy or laparotomy or vaginally is repairing of the isthmocele. Remodeling means reshaping the isthmocele so that it becomes asymptomatic, and repairing means excising the defect and suturing it well to give a good scar. So, sorry. Now, hysteroscopic, if you see this is a hysteroscopic image, this is what it looks like, this triangular defect, what you can see, a wedge-shaped defect. The aim of the surgery, before I show you the video, I am just talking the principle of surgery. In the remodeling process, the surgeon flattens out the edges of the isthmocele so that no blood or menstrual debris can accumulate in the isthmocele site and desiccates the base of the defect. So just to tell you, this is like a deep defect here, acute. What we are doing is making a little shallow defect. So you can't fill it with anything. Just compare it with a ground where there's a big hole and all rainwater is coming there. If we cannot fill this, like this hole, I cannot fill with anything. I cannot fill it with mud, what I'm in contrast to the example I'm giving. So then you can make the nearby area also slightly slopey so that this gutter, the hole which is there in the ground, may merge gradually with the neighboring area. Same principle we are following here. Rather than this defect, we are making the nearby area this shallow so that the blood just flows like this and comes down rather than collecting in that pouch. Remodeling will, and the base also they are doing coagulating the base so that if any stroma is leading to any mucus production or any abnormal bleeding will also be destroyed. Remodeling will benefit only those women who have this thickness has to be very good. So how do you decide? This residual myometrial thickness has to be more than, now different studies 2, 2.5, 3, there are different studies, but I would say 3 millimeter is the safer limit. If it is too thin, your hysteroscopic instrument may just perforate very easily. Now this is a video. Let's play the video. This was, there are 2-3 videos. One of them is good, which I'll play soon after this. Initially, when you start doing these cases and you're seeing them for the first time, we have to identify the disease. This is the ostium. This is an old film. The other ostium. So that is why the importance of vaginoscopy. See, if you hold with Sims and Valsalem and if you've dilated, here while coming out, we will see the defect. As we are withdrawing the telescope, anterior wall, we know Cesarian scar is in the anterior wall. So while withdrawing, we will see a dome-like effect. Actually, it's 2D, so it's difficult to see. Now you can see, this is the outer margin, which you just saw. This is the outer margin, and this is the inner margin. In between, there's a depth, if you can perceive that depth-like perception. In this particular patient, it was more towards this side. In my other video, then we try to resect the, so as I said, a deep hole we are making it little shallow. Slide में थोड़ा slope कर रहे हैं उसके. So resectoscope loop electrode is a good instrument for this. Scissors cannot achieve this. So you have to achieve this. This bulge which is coming down, we are trying to make it little less, just giving few cuts. Now let's move on to the next slide. This was a 41-year-old lady, what Dr. Garima just described. I think she's the same patient, Jyoti Singh. Yeah. This was her picture. Now, vaginoscopy is very important because while entering and while coming out of the cervix, you can make out so many diseases you can diagnose. Sometimes small polyps in the cervical canal, which are missed otherwise, can be diagnosed. So this we are entering here. And you allow the fluid to distend the cavity. The ostia are seen. She was 41-year-old. She had completed her family, but her complaint was mainly menstruation related. And slight this polypoidal endometrium, what you can see. Now, as we are withdrawing, this is the normal cavity. Now you see this dome-like defect. This you see, there are two sort of rims here between this and this, the flat surface which you can see. If we all have visited old forts and all, imagine those forts when we enter, there's a big dome on the top where the sound echoes. It's similar feeling which you get, this dome-like defect you seen here. Now in this is a good area for blood to collect. So I will slightly shave this area and slightly shave the proximal part which is close to me. So as to make the defect slightly shallow. So caudal margins means the one towards the patient's tail end, means towards the surgeon, is being trimmed first. We just have to do the anterior wall and maybe little nicks over the side wall. We don't have to do anything on the posterior wall. This is very important. Inside this is you can see my resectoscope is going into that dome, because that's a lot of hollow space here. So few superficial nicks, gently along some tissue to just fly off. We are not doing TCRE, remember, we should not do too deep defects. We are not going to cut up to the myometrium and all that. So angulation is very important, because sometimes you may have to twist your own body also to get the adequate right approach. Sorry, it went back. It was running. I'll go back. Forward it slightly. So in some of the schools of thought say that in the base, this is a roller ball. The base of the defect, we are putting roller ball to destroy the stroma. This is also another electrode. If you are using bipolar, you can use saline, which is safe for the patient, and all the principles of maintaining fluid balance, etc., have to be kept in mind. So this is a roller ball coagulation. We just, while doing this, we noted a very small fibroid. So we burned it as well. This was a small fibroid which started bulging. And at the end of it, we placed. So this is towards the end. Little more shaving is required, and then this was done. So now, when we look at the literature, there have been two kinds of schools of thoughts. One is you do correction at both the proximal end and at the distal end. The other school says just distal correction is fine. So many surgeons have tried in their own ways. I'm not going to read it out. And because when we are doing correction towards the os, towards the cervix, then there's a small possibility you may cause cervical incompetence. So underdoing is better than overdoing. Undercorrection is better than overcorrection, but then you should create a place which allows the fluid to flow. Now, should you use roller ball at all? Resectoscope is definitely required, but one school of thought doesn't approve the use of roller ball. Others say roller ball should be used because that will destroy the stroma at the end. This is the third video. This is the last video which I have. So this was patient had a difficult vaginoscopy. External os was also difficult to see. I just forward it. And once we reached in tracing the interior wall. So here we found a defect was quite on one side, left side only, that defect was there. Yeah. So as we are coming out, you have to have a lot of suspicion of these cases. Now here you see one defect with some gutter-like defect seen on the left anterolateral wall with some brown spots also, like typical of what you see in adenomyosis and others. Dark colored blood which might be accumulated. Here you see this spot. So this defect in this case is on one side. It may not be a typical dome-like defect which you saw just now in the previous video, and there's a fibrotic band also running in the niche in this area. So this area had to be excised, which we did with a resectoscope. This uterus was found to be retroverted, and she had fixed uterus because previous cesareans may have a ventroflex uterus. It may be totally adherent to the bladder. So here we gave few nicks, especially in that area, specifically in that area. And so another, here, as you see in laparoscopy, it's difficult to reach these narrow areas. These clots I'm just removing like a cold knife, and then going deep, creating a slope in that area, cutting that band of adhesion which was there in that corner, and then creating a slope. That defect is very deep-seated, if you see. So your choice of patients for hysteroscopy would be symptomatic patients and those who do not want to, those who have good RMD, good residual myometrial thickness. Yeah. Second mode of option is, that was remodeling. Now we are talking of repair. Repair can be done by vaginal route also. So we always talk of hysteroscopy, laparoscopy. Why not think of vaginal route? Because this is in the lower part. Just like in a VH, you inject something adrenal or a plain saline, and then you dissect the UV fold. And then you, here in this case, after the UV fold, you will identify the isthmus, and then isthmocele can be excised and repaired. But in this case, you need surgical expertise to avoid damaging the surrounding organs. And you have to make sure that isthmocele is not very high, because very high in non-descent may be difficult to reach. Now coming to the second part, that is laparoscopic. Where will you read laparoscopic? Patient who wants to conceive and those who have a thin RMT, means residual myometrial thickness less than 3 millimeter. Here, the steps are same. UV fold is excised in size and you push the bladder down. And then, now important thing is which part to cut, because on laparoscopy, you may not be able to see where to start cutting from. One can introduce a Foley's catheter and then try to push the bulb into this. Second possibility is, the steps are, you'd see the margins, debride the margins, and then collect, and then suture the edges. Now, identifying the defect, as I said, one is you do first hysteroscopy, now you've seen, and then you do laparoscopy. Second is simultaneous hysteroscopy and laparoscopy. So with hysteroscopy, you see, and then another person with a laparoscope, with only the camera. The laparoscopy person has to put the lights off of the laparoscope so that the lights of the hysteroscopy camera will shine. In this image, you can see the shining images of this, and this is called as hot air balloon sign, just like a hot air balloon. The third way technique is called hooking effect. It's called slip and hook technique, where a 6 number Hager's dilator is placed, and then just like a finger, with your finger, how you would hook, 6 number Hager dilator is placed in the endocervical canal, forwarded blindly at the level of uterine isthmus, and then with a hooking effect, this is brought backwards, allowing sort of perforation, as if you're about to perforate, and then the laparoscopic person can give an incision at that place. And then you keep the Hager's there so that the suturing keeps the cervical canal patent. This, I did not have a separate laparoscopy repair of isthmocele, but I have the cesarean scar ectopic which I had repaired, so I thought I'll share. So whenever you do laparoscopic repair, you're bound to get some adhesions in the mental adhesions. And these ventrofixed uterus, just like a lizard, they're hanging on the wall. They have to be dissected carefully. Here I've done filling of bladder gradually, because you have to expose the lower uterine segment. This was an initial case of cesarean scar ectopic, and here we used to do uterine artery ligation, lual in the beginning. But now we have realized that it is not required, doesn't bleed so much. So this was an ectopic, just to show you the steps. This was cesarean scar ectopic, but similarly in the Hager dilator also, somebody is pushing, you will know this is the thinnest part. Excise the part and then repair the area and layers, and then reperitonize. So this technique was described by Donis, and they did the cutting with laser and then repaired the defect. So if you look at the management plan, it's too small a thing, but just to summarize, I would just read: if patient is no wish to conceive and she is asymptomatic, leave her alone, just follow her. If she is symptomatic and her RMT is more than 3 millimeter, hysteroscopy. If she is less than 3 millimeter, then laparoscopic. Now, if patient has infertility or associated symptoms, then again RMT less than and more than will decide hysteroscopic or laparoscopic route. But if she wants to conceive, better to do a repair rather than just remodeling. If we look at results of treatment, AUB, that post-menstrual spotting has shown to be, the result has been satisfying to 59 to 100%. And different authors are giving their different codes, up to 6 months follow-up. Infertility, infertility patients, infertility is actually not just one cause, it can be multiple causes, but results after hysteroscopy very good. 100%. Others, with laparoscopic repair, success rate can be 44% by Donis. Pain dysmenorrhea, again, is not so commonly seen. Obstetric outcome, we have found that wherever you got a good RMT, the results were good. And they have found that RMT means residual myometrial thickness increase after hysteroscopy as well as after laparoscopy. Even after hysteroscopic slope that we are increasing, still we found that overall myometrial thickness was slightly better. Maybe the defect was close, so it looked better. Repeat procedure in some studies has been required in some one of like out of 8, 6 got relief and 2 required a repeat procedure. So this was all about. I'll stop sharing.
So that was a very good presentation, Dr. Jyoti, and you are such a wonderful teacher, and you've covered all the aspects of Isthmocele. There's nothing much to add to it. This is just the price that we are paying off, maybe because we want to have safe practice and increasing number of cesareans. Because when we were like studying and we were PGs, we did not face these problems. These came into being. And I think one reason was because we were doing 2-layer closure also at that time. Because 95% of the patients who had this isthmocele had single layer closure of uterus. So this concept which came of single layer closure and keeping the and not closing the peritoneum, I think that added to this increased incidence of isthmocele. And the best now I think everybody agrees that it should be double layer closure. And if the myometrium is very thick, so it's better to first close the lower part of the uterine wall, and then the second layer take the upper part, and not too tight and not locking the sutures, and achieve hemostasis. All that will probably decrease the incidence of isthmocele, I guess. And
Problem is when she has been already in labor, no? One lower segment is so thin and upper is so thick,
Yeah.
so it's not homogeneous closure. What do you
Yeah.
say about that? Like that becomes a problem, advanced labor cesareans.
Yeah, as the aim should be to make it as anatomical as possible. That is it. And for that only I was saying that if it is like too disproportionate, then maybe we can in 2 layers first try to approximate the lower the part
Inner
close
part.
to the endometrium, and then come to the upper part and make it more anatomical.
So that's what you correctly said. This problem we are facing because of increasing number of cesareans. And when they come to us for TLH, we have hard time. Everybody with a stuck bladder. So these are the problems nowadays. Ectopic pregnancy, cesarean scar ectopic has become so common.
My personal feeling is that when we used to close the peritoneum, adhesions were less to the anterior abdominal wall. And
yeah, it's a different schools of thought keep coming.
yeah.
And I have not been closing, but I think there's no harm if you do. It takes hardly 2 minutes to close the peritoneum. Any
Can I add a point?
Yeah, please.
Yes, so correctly, Dr. Tarun has pointed out the technique of cesarean, which we need to really highlight in our juniors, so that because see, cesarean is done by even in medical college, the first year PG is started doing it. So that really needs to be enforced right there. That see, this is not a only cesarean. She has to face other problems in future. So if you talk about the disparity between the upper segment and the lower segment, if you open the UV fold and you really push the bladder, you need to identify the lower segment really well, so that when you're approximating, the two upper and the lower segments are of the same thickness. Sometimes, when we do a repeat cesarean, we find that the previous scar was too high. It wasn't actually in the lower segment, it was almost at the junction of it, especially when you're doing in elective cases, elective cesareans and all. When the patient is in labor, the lower segment is well formed, so that's not a major problem. Another important thing which I would again like to highlight is why the incidence is being increased, because we have now better ultrasound facilities available, 3D ultrasounds, transvaginal ultrasounds, and most important, most of us gynecologists are doing it. So you have a vision to see that, and that is the reason why it is coming up. And initially it was like patients coming with irregular bleeding and all, we were not able to identify that this is the problem. So this may be existing earlier also, but again, not every isthmocele require a surgery or a treatment. They are asymptomatic also. It was a wonderful topic and a wonderful coverage of it.
Thank you, Dr.
Good
Sanchita,
show.
thank you for the inputs. And I would say that the eyes see what the mind knows. So as you said, as gynecologists, and previously, whatever irregular bleeding, either OCPs, progesterone, finally hysterectomy, that used to be the life of the woman. You try hormones and then. So many times probably it was missed in the older times also. And as a cause of infertility also it is coming up nowadays. So if you see one and patient is not conceiving, it may be a good idea to put in hysteroscopy. But we have to remember not overdoing. Otherwise, you may invite adhesions and put her into HMS. That is also not our aim at all. And be very careful because perforations can easily happen. So diagnosis and judgment about the correct selection of cases is very important. Any inputs from the audience? We see a lot of names here. Anybody, any experience anybody has done an Isthmocele or would like to share? So I think we need to close now and we'll come back next month again with another interesting topic. Thank you, Dr. Taruna, for taking out time and coming as a guest of honor.
Thank you so much for having me. It's always a fun to be associated with JP. Like I spent 5 years, very good time with you all. So it's fun.
Yeah, so I think we continue with webinars because I think it's easy for everybody to understand, to attend and more cost effective. Just accept, I think initially 4-5 minutes every time it takes to start and then the speed goes. So thank you once again, Dr. Garima, thank you for presenting the case. Dr. Taruna, thank you all the audience for being there. Without you, this wouldn't have been a success. Thank you.
Bye.
Bye. Bye, everybody.